Excellent. Thanks. Thanks, Asim. Hi, Weejay. Good to see you again. Should I just get started? First up, we're having our yearly conference. It's going to be a virtual conference in October of this year, so you're all invited to come along. It's going to be a very discounted event, and we do like to get all of our friends from out of the country into these meetings if at all possible. Disclosures. My background is I'm an upper GI and bariatric surgeon, sleeve gastrectomy and banded bypasses since about 2004, and preferential endoscopic management of complications since 2005. So I'm going to predominantly talk about endoscopic management and my thoughts and perceptions about endoscopic management of leaks and how to classify leaks to then better have conversations with people about how to treat them. Bit of history. Stents were really the mainstay of management of leaks endoscopically until recently. And I've been a very enthusiastic user of stents in the past, but I'm not entirely impressed by their management for a whole lot of different types of leaks because it's a very binary tool. And you can end up sometimes with patients with multiple stents not going anywhere. We're not that good at classifying leaks. If we're trying to describe a superficial wound infection to our colleagues, we'll usually do a pretty good job of it, but we lack clear classifications about how to look at different types of deep surgical site infections. So this is how I classify them, and it's what I teach my trainees. And what I'm interested in when I'm looking at a leak or managing a patient with a leak, I want to know whether the infection is localized to the stomach or whether it's become lateralized, whether it's early or persistent, or whether there's a stenosis. And the methods that I'm talking about are predominantly going to be used for sleeves, but they work for roux bypasses, gastrectomies, and esophagectomies as well. The first type of leak that you might get, which is a relatively simple one, is really just cellulitis or a phlegmon. I'd still like to endoscope these patients just in case there's a small abscess there. And you can see I've got a cap on the end of the scope. And the cap allows you to really get a good look at the staple line. A lot of times when surgeons endoscope patients, they don't see the hole because it's at the side. And a cap on the end of the scope allows you to see the hole very well. So that's phlegmon. I'd call it a type 2 or an abscess, localized abscess with or without contrast extravasation. A 2A, which is a small abscess, or 2B, where you've got an abscess that's drifting away from the staple line and is relatively large and unstable. Type 3, I'd call a free leak, where you've got peritonitis, and clearly these sorts of patients are going to end up requiring surgery. You can see gas in the pelvis for this particular patient. And then there's chronic fistulas. But again, most chronic fistulas can be classified as well. You'll generally either have a cavity which is close to the staple line, or type B, which is a lateral cavity or draining fistula. I've mentioned stenosis. I think endoscopy is specific but very insensitive. And often when surgeons endoscope patients, they're actually not that interested in finding out whether they've created a stenosis, and it tends to be undercalled. And when you're endoscoping somebody soon after a sleeve, a very good diagnostic test at your index endoscopy is to dilate up through the scope balloon to 20 millimeters and pass it through the stomach and see if it catches anywhere. That gives you a really good idea if there is a stenosis. And after a few weeks, dilatation of a stomach up to 30 millimeters or more is safe for a sleeve after 2 weeks, and about 6 weeks with a gastric bypass. And this is therapeutic and diagnostic. If you've got a patient with a long-term leak, a 3D functional CT can also help assess the leak in relationship to a stenosis. And I'd generally assume that all persisting fistula or abscesses have at least a functional stenosis, if not a proper one. And this is what I mean by stenosis. You can see a 3D CT scan of a patient with a sleeve leak 6 weeks down the track. And when you dilate the 30mm balloon, what you see is a stenosis at the angularis with a wasting of the achalasia balloon that fails to fully expand. But if you dilate these patients a couple of times, very often you can get away with not having to do anything complex, as the stenosis is functional rather than real. Early leaks, I think the cavity, any stenosis and an ileus are the main drivers. You clearly have to resuscitate the patient and give them antibiotics and consider nutrition. But I'd like most of these patients to be considered for rapid discharge, especially people with localized abscesses. And there's very few sleeve leaks I won't get home within 1 to 2 weeks now. My feeling is that the length of the hospital stay and degree of suffering faced by the patient is going to be proportionate to the late medical legal risk. I think people should try to avoid surgery and try to avoid resection surgery if surgery is needed, just in case it doesn't work.
Sorry, Michael, just a moment. Could you hang on? Please, could you mute your mics? Thank you.
The other thing that happens with patients who have a long time in hospital is this appearance of stability. If the patient is the same at the end of the week as they are at the beginning of the week, they're actually getting worse. And so we can often end in a situation of surgical inertia where a patient spends many days or weeks in hospital without actually improving, waiting for the next disaster to occur. So I think if patients aren't improving within a week, we should consider moving from one treatment strategy to another. That's one of the advantages of endoscopy. You can move on from one thing to another very quickly. So how to actually manage these patients? Phlegmon, so inflammation without an obvious abscess, clearly IV antibiotics and observation for a couple of days, but I'd still have a low threshold for endoscopy within the first 24 hours of admission, as per the video I showed before. Patient with a medial abscess, traditionally we've performed laparoscopy with drainage or CT-guided percutaneous drainage. The problem with that is it creates an external fistula unless you go ahead and remove the drain relatively early. And you can see in the center here, this is the fistula tract of a patient who had a drain in for 6 weeks and now has an ongoing leak because of the external drain. With these patients, my preference is to use endoscopic internal drainage. It's suitable for sleeves, total gastrectomies and staple line leaks and bypasses. It's very fast, it's very cheap. The equipment costs almost nothing. It avoids creation of an external fistula and allows you to assess your defect, whether there's a stenosis and your anatomic configuration. If you wish to, you can place a nasojejunal feeding tube at the same time. And the majority of patients will have oral fluids on day 1 and be discharged within a week. And these are the sorts of patients that, cases that I'd treat. Here's a patient with a 3 or 4 centimetre abscess next to the staple line within a week of surgery. With the cap on, we can see the defect very easily. It's a tiny defect. And you can put the cap against the defect, aspirate the pus out, and then put a guide wire and some contrast in to assess the size of the cavity. The cavity is large enough to take a guide wire, then I'll put in a pigtail stent like this. It's a very small cavity, often just sucking the abscess out will be sufficient treatment for patients with very small cavities. So this is a self-retaining double pigtail stent, and you leave it in place for a month to 6 weeks. But very often as the cavity gets smaller, the stent extrudes and passes by itself. If a patient's got a larger abscess and is more systemically unwell, then a localized treatment like this won't work, although you often don't lose anything by trying endoscopic therapies first and then reassessing the patient the following day, because you can always escalate your therapy if you need to. But these patients are more complex and they're unwell. They may have an ileus and or a stenosis driving up the intraluminal pressure and the leak volume. In these patients, you want to get rapid control and effective drainage. So these patients, I'll do a laparoscopy and place an external drain, but I'll also pass a fully covered stent to cover the defect, and I'll suture the stent in position so it doesn't migrate. Or the alternate is an endosponge placed endoscopically for somebody presenting a little bit later. Both of these are excellent. However, I think you should terminate the endosponge or remove the stent after about 2 weeks. Mostly these patients need TPN and they're stuck in hospital and the stents are uncomfortable. I'll describe the endosponge. I think we've probably got time. It's cheap, but it's not as easy as it looks. You need a big hole in the staple line for it to be successful, and you need to repeat the endoscopy every few days, so it's resource intensive. There's a patient with a large defect going out over the top of the spleen, failed internal drainage, localized sepsis, large abscess, had previously had a laparoscopy and stent, but the stent failed, so it was removed and replaced with internal drainage. Now washing the cavity out to show you the size of it, going all the way over the top of the spleen. The endosponge is just a piece of vacuum sponge put on the end of a nasogastric tube and sutured to it and picked up with a snare. And what you do with your scope is you push the endosponge past the hole and then use the scope to push the sponge into the cavity. And what you want to try to achieve is to have the sponge extraluminal and the lumen of the esophagus and stomach unimpeded. If you obstruct the lumen of the stomach or the esophagus with the sponge, you'll get preferential drainage into the cavity, which isn't what you want. You actually want preferential drainage of saliva down the GI tract. And here's just pushing the endosponge back in to make sure it's straight. And this patient had the endosponge for 10 days and had it replaced with a internal drain. And I was able to recommence liquid diet after 10 days. This is showing a stent that's been removed, tiny little cavity at the end. Once the stent was removed, as the peripheral cavity was very small, it was replaced with an internal drain and the patient was sent home on a liquid diet. If the patient has generalized peritonitis, then I'd usually perform a laparoscopy, lavage and drain. And I'd do, once again, an on-table endoscopy and a covering stent and suture the stent in place. These patients will need TPN and they can be quite unwell, but I'd still aim to remove the stent in 1 to 3 weeks once the patient's clinically well and the ileus is settled, and plan to remove the external drain if possible to avoid creating an external fistula. I don't love stents. They're not well tolerated and they tend to occlude as they straighten. And when you endoscope somebody with a stent who's had a sleeve, this is what you'll find: an obstructed distal pseudopolyp with decubitus ulceration. So the stents become obstructed as it's straightened out. And if you leave this for long enough, the stent will often erode and that can be a disaster. I'll tend to only use stents for a sustained period of time if it's the only alternative and other things aren't likely to work. So a sleeve with a large hole and a stenosis, or a patient with an external drain. I'm going to touch briefly on chronic fistula, but not show any videos. I think this is usually associated with lateralization of sepsis, and it's usually also associated with prolonged unsuccessful therapy when the clinician's not accepted that their therapy is not working and they've stuck with something that isn't working, and they've encouraged the sepsis to become chronic. There's often a stenosis and often preferential drainage into the cavity. Clearly, these patients, the bacteria changes from virulence factors to persistence factors. And my therapy for these would usually be internal drainage and pneumatic dilatation, 30, 35 to 40 millimeters, plus or minus septotomy. These patients are usually on an outpatient on a fluid diet. And you can see in the center there a very tight looking sleeve, but even this patient was able to be managed with dilatation and avoid surgery. So quite complex stenoses can often be managed without surgery. Actually, I do have a very quick video showing a septotomy. This is a chronic cavity in an outpatient. I'll just move on a bit. dilatation, and this is the septotomy with a needle knife. And again, the cap, what we're doing is just opening up the staple line where the staple line occurs to join the two cavities and allow marsupialization. It's a relatively straightforward thing to do. That's scary the first few times you do it. And if surgery is required in these patients, my preference is roux fistula enterostomy rather than radical resection surgery. The patients have asked for a sleeve, they want a sleeve, they don't want a bypass, they don't want a total gastrectomy. If you perform a roux enterostomy, other options, including conversion to bypass or total gastrectomy, are still available to you. If you've done a total gastrectomy, then you can't go back. So in conclusion, just inside time, I think early and recurrent use of endoscopy is invaluable for assessment, drainage, dilatation, stenting and feeding. Over-reliance on stents can be discouraged these days because we've got alternate technologies. And I think we can avoid external fistula by abandoning methods that prolong external drainage. And when we're treating these patients, we want to focus on drainage, ablation of the cavity and treatment of stenosis, preferably aiming for a rapid discharge. Thanks very much for your time.